So welcome everyone. It's really good to see so many people joining us today on our open session for vets, radiographs for decision-making in thoracic and abdominal emergencies. Thank you very much for joining us this evening. Before we start, I just want to let everyone know that this session is being recorded. Please also keep an eye on the chat box where we will share a link for you to register your attendance and to receive your certificate of attendance at the end of the session. My name is Beth Dunn and I'm the Programme Coordinator for the Diagnostic Imaging Blended Online Learning Programme at Improve. And with me tonight, I have Charlotte Taylor, Product Development Manager, Gemma Coleman, Digital Learning Coordinator, and Abby Caine, a European and MRCVS recognised specialist in veterinary diagnostic imaging. This evening, we're going to start with an overview of the Diagnostic Imaging Blended Online Learning Programme, including a quick demonstration of one of the interactive video lessons. After this, we will turn our attention to the talk of the evening, where Abby Caine, the Course Director of the Diagnostic Imaging Blended Online Learning Programme, will share her knowledge on radiographs for decision-making in thoracic and abdominal emergencies. So we'll be taking questions via the chat box at the end of the session, and there'll be an opportunity for you to ask us questions about the Diagnostic Imaging Blended Programme and to ask Abby questions about her presentation. And you can use the menu shown on the horizontal bar below to send us your questions, and a link will be added to the chat box for you to receive your CPD certificate after the session. So to start, Charlotte Taylor is going to give you a brief overview of Improve International.
Thank you, Beth, and good evening, everyone. Some of you will be familiar with Improve, but for those of you who are not, we thought it would be helpful to give you a brief introduction. Improve has been providing CPD to veterinary professionals globally for over 20 years and was the originator of modular CPD. We are continually adapting and innovating our teaching and learning style from face-to-face lectures and practical training to the more recent online learning programs. We are a truly global company offering CPD in countries as varied as China, Japan, Australia, and many European nations. In 2021, we delivered over 400 different CPD courses, providing over 1,000 days of training to the profession. Improve was created by a group of vets passionate about delivering high-quality continuous education to the profession, and this is still the case today. By studying with us, you will take back to practice new skills, knowledge, enthusiasm, and confidence to handle those challenging clinical scenarios. Our programme has been accredited by ISVPS and validated by Harper Adams University. So throughout the programme, you can start working towards a recognised qualification. This could be the GP Cert awarded by ISVPS, who have already awarded more than 5,000 vets with their GP Cert title, or by completing additional assignments, you can achieve the postgraduate award from Harper Adams University. The postgraduate certificate in diagnostic imaging is an eligible entry requirement for advanced practitioner status with the RCDS. Thank you for listening, and I'm now going to pass you to Gemma Coleman, who's going to give you a brief overview of the programme, followed by a short demonstration on our online learning management platform.
Hello and welcome everyone. Our world-leading online learning programs have evolved over many years and were developed to create completely new online learning experience. Content has been developed and reviewed by veterinary specialists and is hosted on a world-leading innovative platform. You're supported on the programme by module tutors who are specialists in their field. The lessons are presented in an engaging video format with various learning activities to keep you interested and help you learn. These include the use of interactive quizzes, labelling images and drag and drop exercises. The programme is supported by a discussion forum where you can interact with your peers and module tutors. In the final week of every module, you'll be invited to a live webinar where the module tutor will lead case discussion, present a journal club or review content from the month. These are your opportunity to engage with each other and with the tutors. You can suggest content and ask questions in advance using the forum. Being online, you can access your learning anytime you want, enabling you to fit your studies around busy practice commitments so that it's easier to achieve that all-important work-life balance. The Diagnostic Imaging Blended Online Learning course starts on the 1st of September and finishes at the end of July next year. There's a break month in December. During this month, there is no new content released, and this month can be used to catch up or review the previous month's content to consolidate your learning. Our world-leading online learning platform provides a truly unique environment in which you can learn. The content is interactive and custom made and delivers a new digital approach to learning. I'm going to briefly explain how it works. 6 of the modules are theoretical modules, and these will be entirely online. These will include pre and post module assessments, so you can evaluate your progress, interactive video lessons split into 3 weeks, normally with 3 lessons per week. There'll be weekly case studies or reflective practice where you can apply the knowledge to real life scenarios. There's recommended reading and a live webinar in the final week to summarise the learning. All of this is supported by the discussion forum where you can share cases with your peers and module tutor, gaining invaluable access to help and advice of a specialist in their field. 8 of the modules are practical, and these will be taught face-to-face in Swindon. On these practical days, you'll have the opportunity to develop not only your knowledge of that module's subject area, but also develop hands-on practical skills. The month practical days are scheduled for will also have pre and post module assessments, a live webinar along with a series of notes and recommended reading for the subject area, which will all be hosted on our online learning platform. We're delighted to announce that registration on the Diagnostic Imaging course now also entitles delegates to access to the RCVS Knowledge Library for the duration of the course. The RCVS Knowledge Library includes access to a wealth of electronic resources, including the latest journals and clinical research. The resource will be particularly useful when participating in journal clubs or reviewing cases. So we'll now move on to an example of how the online learning platform looks. The content is divided into tiles, which makes navigation really easy. You'll see this example is from the Diagnostic Imaging module of Small Animal Medicine, but the layout is pretty similar for the online blended learning programme. We're now going to move on and show you a short clip. So this is from our CT course, from our GP Cert CT, and this is an example of one of the video lessons. So I'll get Beth to play.
Hello, my name is Tobias Schwartz. I'm a veterinary radiologist, and in this lesson we will discuss CT of the pharynx, larynx and soft tissue neck in dogs and cats. By the end of this lecture, you should be able to discuss CT protocols required for optimal imaging of the pharynx, larynx and neck. Should be able to demonstrate familiarity with normal anatomy by being able to correctly identify hotspot activity.
So we can see this is one of the knowledge checks from the lesson. That's just recapping what we've learnt. So Beth's just clicking on the hotspots here to revise the anatomy of this area. And then we'll move on into the lesson.
Foreign bodies. So let's take a moment to recap what we've just learned.
It's another example here of one of the MCQs, which Beth's already had a go at. And we can see we can have multiple attempts at this. And then we'll just watch a little bit more of the lesson after these, just to show you how that plays out.
In this article, that helps a little bit to put them in perspective. And if these cleft palates are untreated, it leads to a chronic rhinitis because of food material going into the nasal cavity.
Lovely. So as you've just seen, all the lessons have an introduction and learning objectives. And throughout the lesson, you'll have activities which you're asked to pause and complete. And these knowledge checks have been designed to summarise the content and help you remain engaged throughout the lesson. At the end of the lesson, you'll be able to move on to the next video or explore some of the reflective learning. We'll present some case studies throughout the course, and where it's appropriate, there'll be images to review in a DICOM viewer, which is embedded within the case studies. So particularly relevant for CT and MRI scans, where you want to spend a bit of time manipulating those images and analysing the material that you've been presented with. So in a moment, I'll hand over to Abby Caine for this evening's presentation. Abby's the course director for the Diagnostic Imaging Blended Online Learning Programme, and she brings with her a huge breadth of knowledge and experience. So I'm really excited to hear her speak this evening. Don't forget you can post questions on the chat box about the course and questions for Abby to answer at the end of the talk. You'll find a link to the chat box in which you can put your email in to receive your CPD certificate. Now we'll hand over to Abby.
Thanks, Gemma. That's a very nice introduction. I hope everyone is ready to go to do some nice diagnostic imaging on this very warm evening. I'm just going to share my screen. Beth, I might have to ask you to stop sharing so that I can take over. Thank you. Okay, hopefully everyone can share my screen. The topic I've chosen to speak about tonight is imaging in small animal emergency cases, because this is a topic that I'm very passionate about, actually. I think it's where imaging can often make some of the greatest differences to patient progress through treatment and also to patient outcomes. So I very much enjoy the emergency side of diagnostic imaging. When I first was thinking about what sort of topics to discuss, I thought I would try and focus it in a little bit, because obviously this is a very broad topic. And I'm going to focus mostly on thoracic and abdominal imaging. Having said that, there is still a huge amount to cover in the field of emergency medicine. So I have decided to limit it even further to looking at which kind of cases present very frequently to the emergency room, in which I think imaging can make a great deal of difference. They're all challenging cases, and the ones we really want to perform well in and employ imaging appropriately is when we can really use it to make a decision as to what's going to be required for treatment for the patient. So looking at the RVC ECC website, they've come up with their top 10, their top of the pops of emergency cases that present to them on a regular basis. So having a think about those top 10, I've selected about half of those in which I think imaging is absolutely critical for diagnosis and progress of the case. And I'm going to really focus in on those topics. Having said that, we will also employ, perhaps in a more subacute diagnostic and monitoring method, imaging to investigate kidney injuries and pancreatitis as well. And to be honest, at some point, patients presenting with bleeding disorders, seizures, and metabolic diseases are probably going to make it through imaging. So they're all coming our way into the X-ray or ultrasound room at some point. But I'm going to really focus on the 5 in the grey boxes, because I think they're the ones that in the first few hours of admission usually are in imaging and having decisions made. Let's start with respiratory distress. Obviously, that can be a presentation that we see with many different underlying etiologies, and radiology is absolutely critical for working out which of the different causes we might see. So let's make a start and look at the possibility that the respiratory distress is caused by a space-occupying lesion within the patient. The first cause of space-occupying lesion would be considered would be pleural space disease, and this would be contrasted to either the presence of a mass within the chest or potentially a space-occupying lesion which is replacing lung tissue, so a pulmonary origin lesion. Here are the 2 causes of space-occupying lesion that is affecting the pleural space. For a start, we have a pneumothorax here on the top left side of the image. It has really classic appearance of increased lucency within the thorax. And in particular, we see that increased lucency here in a band just dorsal to the sternum, giving the impression that the heart is kind of floating up into the air on this band of gas. We also see retraction of the lung margin. So we can see one edge here of a lung margin coming up, superimposed over the aorta, as we see air accumulating in this costodiaphragmatic recess. And of course, we can also see we get greater highlighting of normal structures such as the great vessels as they pass through the caudal thorax. So these are all features of the pneumothorax. If we identify a pneumothorax, we've got two jobs. First of all, to confirm that it is a pneumothorax and no other cause of presentation of respiratory distress. And then secondarily, to attempt to identify an underlying cause. I have to say the vast majority of those cases that present, we don't identify the underlying cause, but in some situations we do get lucky. And in this particular case, we can see a large, thin-walled, gas-filled structure lying here, just sort of superimposed between heart and diaphragm. And there's a strong suspicion that this is a pulmonary bulla. In many cases, if a bulla is ruptured, we don't actually identify the bulla that's causing the leak on a radiograph unless it's been able to reseal and be visible again containing gas. But the presence of one bulla does certainly increase the index of suspicion that this patient has a ruptured bulla underlying its pneumothorax. So gas would be one material which is acquired within the pleural space, causing a compression of the lung fields so they can't expand. The other material would be fluid that we would see as a pleural effusion. So we can see here a nice example on a DV view of a pleural effusion, again causing retraction of the lung lobes and now outlining very nicely those individual lung lobes with deep, broad pleural fissures. Identifying a pleural effusion often is unhelpful in progressing the case towards a diagnosis because actually the presence of the pleural effusion itself often masks the underlying lesion. It can be for any underlying cause, and again, radiographs very rarely give us a definitive underlying cause to work with. So what we would progress the case with at this stage would be usually to drain the effusion, submit the sample for analysis in the lab so we can get some progress on the diagnostics, and then usually take the patient back to imaging, be that radiography, X-ray, or X-ray, ultrasound, or even CT, see if we can achieve an underlying diagnosis. It's always worth in these cases, however, trying to do the best you can with that initial imaging and spend quite a lot of time evaluating each of the lung lobes to make sure that there's no lung lobe that is apparently absent, perhaps replaced with soft tissue that might imply either a lung lobe torsion or a mass being present. And also make sure that we evaluate that the pleural effusion is not unilateral, because that may give us a clue as to the underlying cause. And finally, spend a lot of time evaluating each one of those ribs and other bony structures, because a rib mass can be very easily overlooked and will obviously cause a pleural effusion as well. Moving to pulmonary diseases that cause or can present with an acute respiratory distress, we're usually looking for large areas of the lung that have undergone significant consolidation, so the patient isn't able to undergo normal gas exchange. Here we can see two different examples where we have a complete replacement of at least one lobe with a soft tissue opacity. Here on the left, we've got a small breed dog that has a complete consolidation of one of the cranial lobes, in this case, the left cranial lobe. And if we look very closely, we can see that this isn't a completely homogeneous opacity here. There's a few gassy bubbles, which is a presentation of a vesicular lung pattern. And this, particularly combined with that clinical history, particularly if it's a characteristic breed, such as a pug, is very suspicious radiographic evidence of a lung lobe torsion because they are predisposed in the cranial lung fields. On the contrary, we have here a large area in the left caudal lobe, also I suspect affecting the caudal subsegment of the left cranial lobe. And this has a completely homogeneous opacity. We get the impression we're getting a little bit of displacement of the cardiac silhouette away from this area, which implies that this is larger than the aerated lung would be if it hadn't been replaced by whatever's going on here. So there's mass effect leading to this mediastinal shift. It also has kind of a rounded border. These are all features that lean a little bit towards a neoplastic origin here, and this was ultimately diagnosed with a bronchogenic carcinoma. The other feature to look for is that we have a little bit of widening here of the caudal mainstem bronchi. This is a location of the middle tracheobronchial lymph node. There's also quite a significant opacity here, so we could also have further tracheobronchial lymphadenomegaly, which obviously is implying some metastasis in this case. So having areas of consolidation can have broad differentials, but looking at these kind of characteristic patterns and more subtle radiographic features will sometimes allow us to prioritize our differential lists and do a slightly better job than just saying, gosh, there's an awful lot of white in that lung. I don't know why that's there. This case was one that didn't fit into either of those characteristics. It wasn't a case that had pleural space disease, and actually this area of increased opacity, the soft tissue present here, is located in the craniomediastinum. These patients usually that have a craniomediastinal mass usually don't present particularly acutely unless for some reason that craniomediastinal mass has rapidly expanded. But I thought this was quite a nice case to discuss and to get you guys to get some thinking juices going. This patient did present with our ECC team. He was a long-term oncology patient which had a melanoma, and it was found that we had a very rapidly enlarging craniomediastinal mass present. So as part of the initial evaluation, it was noticed that there's quite a lot of specks and spots scattered all over the lung field. So the question we had for evaluation was, does this patient have evidence of metastasis? Because that might very much affect what we are going to find. So if people would like to vote, I think it would be very interesting for us to then discuss whether we think this patient has got pulmonary metastasis or not. As there's only a couple of choices, I think we won't give too long to allow people to vote. Well, this one seems to have split the decision making as to whether the patient has metastasis or not. I don't know if you guys can see the results of the poll, but we have slightly under half of those watching thinking that the patient does have METs, and slightly over half thinking that he doesn't have METs. And to be honest with you, I completely agree. This is a very challenging case, which is why it's a nice one for discussion. If we have a very close look, the majority of these little foci that are superimposed over its very large soft tissue of its craniomediastinal mass and also over the cardiac silhouette are very opaque and quite angular in nature. They are in some places larger than the vessels that we can see, but the majority are very small. I would say that the largest is probably only a couple of millimeters across. They do seem to be more marked in the ventral and peripheral lung fields, like we've got a few out here. So for me, the majority of these are behaving as I would expect for an incidental age-related change, which gets different names depending on which reference you use, but many people would call it incidental pulmonary heterotopic bone formation or pulmonary osseous metaplasia. Whatever you call them, they're incidental findings that some dogs get occasionally quite dramatically, as we see here, just as an age-related finding. However, if we look over here, this structure is behaving a little differently. And this would make me change my opinion from incidental findings, as I see here with this angular osseous structure, and these small, very opaque specks here. This is not so opaque as even these tiny little specks. So this implies that this is a soft tissue nodule. Indeed, it has a similar opacity to this vessel as it comes out here. So we would expect, because these nodules, if they're completely round, for them to have the same opacity as a vessel at the same level. However, it is slightly larger than the diameter of this nearby vessel. So that makes it much less likely to be a vessel seen end on. And sadly, this dog had, on very close inspection, around about 4 or 5 of these nodules. And therefore, unfortunately, we need to put this dog in the category of very likely to have pulmonary metastasis from his melanoma. Before we move away from respiratory distress, we have to remember that some patients will present with respiratory distress of pulmonary origin, and yet they will not have a solid space-occupying lesion replacing or compressing the lung fields. And the most classic sort of appearance of that would be cats presenting with an acute flare-up of feline bronchial disease. These patients, if you have a quick first glance, often don't have sort of striking abnormalities. We need to look really close. And a patient that has this degree of inflation and no focal lesions should have really quite lucent appearing lungs. So when we look closely, this patient not only has a relatively sort of opaque appearance, almost a scruffy appearance of the lung markings. If we look really closely, we can see that we have multiple donuts. So this would be defined as bronchial rings. In a couple of places, we can see lines as well, these parallel lines indicating a bronchus seen side on. So this kind of bronchointerstitial lung pattern is fairly characteristic of a feline bronchial disease. When they present very severely, they may also have marked gas trapping, so they may appear progressively hyperlucent, but despite that, we will usually see some preservation of this bronchial pattern, and it'll be discrepant in terms of its degree compared to what we would see with the bronchial changes. We may also see additional changes such as a sort of secondary pneumonia or even some lung lobes, particularly the right middle lung lobe, becoming collapsed. But say our patient, and this is specifically talking about cats, is particularly unstable with their respiratory distress, and we're genuinely frightened that if we take them out of the oxygen tent and try and put them on the x-ray table, they may genuinely go into respiratory arrest because they're so severely affected. We do have an alternative option to have a look at our dyspneic cat, and that would be to apply some the ultrasound probe onto our patient. So I've got 3 different examples here of conditions that we have discussed today, and this is giving the ultrasound appearance of these. So let's start with this little clip here. We can see that we've got areas of completely consolidated lung with a very irregular margin. This lung does not look normal at all. And as the patient is breathing, we can see we've got echogenic, slightly speckled black surrounding, which is a degree of pleural effusion. So ultrasound is very good at detecting pleural effusion. It's actually better than radiographs for a small volume effusion, and allows us to look through that effusion and actually analyze what's going on with the lung beneath. So it's very easy for us, therefore, to start to make an assessment as to what's going on within the lung as well as the effusion surrounding it. Here we've got an example of a patient that has a pneumothorax. We can see that when we place our ultrasound probe on the body wall and we peek through the two ribs, so we have a rib here and a rib here, we see normal visibility of the structures of the body wall and the intercostal muscles. And then we get this hyperechoic reflective interface, which is the edge of the lung. We can see mostly that this lung is gliding. This is the glide sign showing that the lung is aerated and that it is moving. And we can see here where we have pneumothorax that there's still air, but it's completely static. So this is the edge of moving lung against pneumothorax. So it can be a very sensitive technique for detecting both the presence of pneumothorax, but also having an estimation of how very large the pneumothorax is by working out where on the chest wall that gas that isn't moving is visible. I want you to notice one other thing, which are these parallel lines that we see as part of a reverberation artifact. These are called by some of the ECC specialists as A lines, and they are parallel to the surface of the lung. And this is seen in any kind of aerated lung. If the lung starts to develop a degree of alveolar lung pattern, we start to see these lines that run perpendicular to the long axis of the surface of the lung. And these are called B lines, or for some people, they call them lung rockets. The idea is they're supposed to look like little, almost fireworks coming away from the lung surface. And so these B lines are a hallmark that we have a degree of alveolar pattern present. So by combining these different ultrasound appearances, and particularly if we develop some real confidence and experience with doing this on a routine basis, we can actually use ultrasound as our first line method to assess the patient right by the cage side before we take them into radiography, perhaps for a better overview of the entire lung. Let's move to heart failure. This will obviously be combined with respiratory disease, particularly if we have left heart failure. So as mentioned before, when we see increase in opacity consistent with an alveolar lung pattern, one thing that really helps us to work out what the cause is to look at the distribution throughout the lung fields. And the most common location for left heart failure leading to pulmonary edema within the dog would be in the perihilar region. So this is a really characteristic case. This is a Cavalier King Charles with global increase in cardiac size. But in particular, we start to see a left atrial tent appearing here, which is causing elevation both of the carina and the main stem bronchi as they move away from the carina itself. But we can see superimposed on this, we have this diffuse hazy appearance, which is interstitial to alveolar in opacity. We can see a few other areas are affected. In particular, we can see a little bit around the margin cranioventrally. So as the progression into cardiogenic edema occurs, it will spread out and affect greater volumes of the lung. And in reverse, as it is resolving on diuretic treatment, then we should see that again returning back to the perihilar region and eventually completely resolving. So this would be the kind of characteristic appearance we would expect to see with our left-sided heart failure. Note in cats, they really don't read the textbooks of the dogs when it comes to cardiac failure, and they can be much more random. So they can have a multitude of different pulmonary patterns still most commonly alveolar, but it's often patchy and randomly distributed. So cats are a little bit more challenging to rule this in or out. And I think combination in cats with point of care ultrasound and an echocardiogram to assess left atrial side is really vital. Sometimes we see cardiomegaly and we can't really recognize that left atrial tenting causing this angulation just caudal to the carina. Instead, we get an impression of a more global cardiomegaly. So here we see it on this DV view. It looks like the dog swallowed a football. On both of these views, the other thing that strikes me is how very crisp the margin is of this cardiac silhouette, again here. And we get this crisp silhouette if we're not getting movement blur from cardiac motion during the exposure. So there's only really two things that will lead to this very crisp appearance. And one would be a pericardial effusion, because obviously the pericardial sac is not moving. The heart is just beating within the pericardial sac. So we get a very crisp outline. And the other disease would be a cardiomyopathy, such as DCM, where the cardiac beating is so weak that we really don't see much in the way of movement. And of course, to distinguish the two, you may get some clues from cardiac shape. So DCM in particular is very commonly leading to a left atrial enlargement. So that would be one clue if that was present. But again, if in doubt, it's very easy to place the ultrasound probe. And if we see this kind of appearance where we get the heart sat within a sac of pericardial effusion, then that should be quite clear that we have a pericardial effusion, and that needs to be managed. One feature to look out for when we're looking at pericardial effusion is whether the right ventricular wall is kind of undulating in and out and collapsing at points in the cardiac cycle, as we can see here. This would therefore be a cardiac tamponade and would lead relatively rapidly to right heart failure developing. Here is a case with right heart failure. This was actually another Cavalier King Charles Spaniel, and this patient had a combination both of left atriomegaly and a little bit of suspected left heart failure, but also right-sided heart enlargement and right heart failure. So in the dog, the hallmarks of right heart failure are not within the lung fields. They may be within the thorax because the patient might develop a degree of pleural effusion. But we also need to remember to look into the abdomen, because these patients will usually start to develop back pressure via the chorda vena cava, which might be enlarged. So it would be significantly larger than the aorta potentially. We may start to see a degree of hepatic enlargement and also the development of diffuse ascites, as we can see in this patient here. So the next topic I'd like us to look at is trauma within the chest and abdomen. So trauma can obviously take many different routes to present. It might be a blunt type trauma, such as an RTA, or trauma for another reason, such as a fall. And the etiology of the trauma will obviously lead to different appearances radiographically. So these are kind of broad considerations of things to look at rather than going in depth through each of the different trauma types. Let's start again, as we've been working in the thorax here, with the appearance of pulmonary contusions. These quite commonly will not be at their greatest in terms of radiographic visibility when the patient first presents. And I think that's something always to remember. If you're very efficient and quick off the mark performing thoracic radiographs, then you might see a negative finding, no radiographic evidence of contusion within the lungs. And yet if you were to go back and re-radiograph those patients at 24 hours, then there may be more significant change. The other thing to remember about contusions is they're quite commonly occurring opposite the side of trauma, and that's something to bear in mind when planning which radiographs you're going to take. Obviously, in an ideal world, we would end up with both lateral views and at least one orthogonal view, so either the DV or a VD view in these patients, so we can fully evaluate every part of the lung. However, these patients may be unstable and also might have concurrent disease. That means we don't want to move them around very much within the radiography suite. So for this reason, if you see that the patient has had trauma on one side, bear in mind that when planning which radiograph to take. This little cat presented following an RTA. We're around about 24 hours in, so this is probably about maximum appearance of our lung contusions that we have here. On the lateral view, we don't see very much dramatic. We can see the diaphragm appears to be intact. We don't see any evidence of pneumothorax or pleural effusion developing, but we do have an impression in a couple of locations that there is a little bit of increased opacity, both cranial to the cardiac silhouette, and also this kind of wedge shape of increased opacity noted caudal to the cardiac silhouette. On the DV view, however, we can see that actually a large portion of the left side of the lung, probably affecting multiple lung lobes, both cranial and caudal, is completely replaced with an alveolar lung opacity. So the degree of opacification will obviously be dependent on the degree of hemorrhage that's present. But one feature that we commonly see with lung contusion is that there's very little, if any, mass effect present. So it's as if the contusion fills the alveoli in situ and replaces them with hemorrhage, but it doesn't really expand. It is possible to have a genuine hematoma form, but they are much less common than this diffuse hemorrhage within the normal air-filled spaces. So just a reminder of 3 different cases here which have different appearances of mediastinal displacement, which can help us work out what the cause of the opacification is. So here we have a patient that had a pulmonary tumor, and we can see that we have mediastinal shift away from this mass within the lung. Here we have our pulmonary contusion cat. I've flipped the radiograph just so we can always see the pathology here on this side. But actually the cardiac silhouette is relatively still within the center here, so there's no mediastinal shift to speak of. This patient, alternately, had general anesthesia and had been lying on its right-hand side, and now we can see mediastinal shift towards the area of lung opacification. So this here is the presence of atelectasis, which most commonly we see secondarily to some kind of radiographic error, I guess, of allowing the patient to lie on one side prior to taking the imaging. So bearing in mind the concept of mediastinal shift, we can help to really evaluate the cause of some of these lung opacifications. This patient I saw quite recently, which hopefully it'll be fairly apparent that we have a pneumothorax in this case. It was a post-RTA patient. So an evaluation, I could see again this band of lucency giving the impression of a floating heart. We could also see a little bit of a retraction here of the lung field from the diaphragm. One feature that then caught my eye is that this patient has an area which is kind of ovoid in nature towards the periphery of the lung, which has increased opacity. And in the context of a patient that has recently had a trauma, then really we're thinking of some kind of hemorrhagic lesion. And when it has a very sharp margin like this, then the top differential would be a hematocele. So we can see here that we get basically blood filling a pulmonary bulla, which might be traumatic itself in origin. These usually will resolve over a period of time. So actually the main form of management here is to keep an eye on the pneumothorax and ensure that it is not progressively increasing in size. So moving forwards, here we have an example of a patient that has progressed in size of the pneumothorax. This patient initially presented and we could see bilateral pneumothorax. So we have here a band on the right-hand side, and we also have a band on the left-hand side. They're roughly similar in size. If anything, the right side is slightly larger. And we can see that the diaphragm is also quite symmetric in appearance. About 4 hours later, we could see that we have increase in volume of gas on the left side, which is leading again to that impression of mediastinal shift. We can hardly see any gas now on the right side, and we've lost visibility of our lung completely on this left-hand side, and there are these very collapsed looking structures here very close to the hilus. We can see that we have asymmetry here of the diaphragm, and we actually get expansion here on the left side compared to the right side. So this patient now has a tension pneumothorax. And this kind of appearance with shift of the organs on this side is a very worrying sign that needs to be detected. And this shows, I think, this case, the utility of monitoring these patients progressively with radiography over time. We can see gas forming in other locations within the chest, often less concerning. The reason why a tension pneumothorax is a concerning feature is because gas that is progressively being leaked into a closed space. Here we can see gas that's forming within the mediastinum. And these patients have a very different pattern of gas accumulation. In this particular case, we can see the walls of the trachea are very clearly highlighted, and that is because we've got gas not only inside the trachea, but also in the mediastinum outside of it. And we're starting to see a little bit of definition of these cranium mediastinal vessels, which normally would have soft tissue against them and therefore be effaced. If we look, we can actually see there's kind of mottled gas opacity here at the thoracic inlet, and this gas opacity appears to track into the cervical fascial planes. And it's very common if we see trauma leading to air leak within the cervical region, that actually this continues down and extends into what we'd call a pneumomediastinum. Pneumomediastinum can happen traumatically without trauma within the cervical region. If we get a trauma quite proximally in the lung, and it allows gas to kind of track up the bronchial tree and leak instead of into the pleural space, into the mediastinum itself. But because it is an open space, it can extend and kind of the gas can escape into the fascial planes. So we rarely see these causing the same problems as a pneumothorax may cause. Whenever thinking about pulmonary gas and abnormalities, we must always pay a lot of attention to the possibility of a concurrent injury. So studies have shown that if we identify skeletal injury in the chest, then we are much more likely to identify sort of concurrent injuries elsewhere. So if we see rib fractures in the cranial few ribs, then we need to pay a particular attention to the forelimbs and in particular to the scapulae, because they're very nearby. It's very easy to overlook a scapular fracture. If we see rib fractures in the middle segment of the thorax, we need to pay a lot of attention as to the possibility of having a contusion within the lungs. And if we see rib fractures caudally, I'm paying particular attention to make sure that we have a complete intact diaphragm alongside it. In this particular case, we see very little evidence of trauma leading to contusion, and we don't identify a rib fracture. But on looking very closely, we can see that instead of having a nice intact scapular spine, when we come to here, we get an abrupt angulation of our scapula. So we've got a scapular fracture. very difficult to identify on the lateral view, and actually the DV view is usually the best view for identifying these scapular fractures, although on the lateral view I do spend quite a lot of time trying to make sure that we can see a nice scapular spine and no stepping in either the caudal or cranial border of the scapula. This was actually the same patient, and not only did we see some fractures at the sort of free edge of the scapular border, there was a very small step down here, quite close to the neck of the scapula. So very easy to overlook these sort of concurrent bony traumas. Here we've got another patient that presented with some evidence of contusion, particularly seen sort of in the midline here of this patient. And this one had obviously more caudal trauma to the thorax. And actually in this patient, we identified not change in the diaphragm, but trauma even further caudally. This patient had a bilateral sacroiliac luxation. So I think when you have bilateral disease in the pelvis, it can be very difficult to spot that because we almost have symmetry between the two sides. But the clue for sacroiliac luxation is to see where the joint space of the sacroiliac joint, it would be on the ilium, and see where it should be on the sacrum. And here we can see that it's stepped forward both on this side and on this side. So a bilateral sacroiliac luxation here. The final trauma to always bear in mind is the possibility of spinal trauma. These can be frighteningly easy to overlook, and particularly they can be very easy to overlook if we have just a single view or a slightly rotated or oblique view, which is very common. So my rule of thumb is until we are very confident clinically that we can rule out the possibility of a spinal fracture, we treat these patients very carefully as they go through imaging. This patient here indeed does have a spinal fracture, and actually our first radiograph that we took was a DV view of the thorax, and even on very close inspection of the spine I find it very difficult to identify this fracture. There are some clues that we'll come back to in a second. When we put up the lateral view, we can see very clearly that we have a shortened vertebra here on T12, and we can see a lucent line which is crossing the vertebral body, and actually even a step here of the ventral border and the dorsal border of the vertebral body here. So actually now we know that the fracture is at T12. Let's go back to our initial view when we didn't have the orthogonal view and see what we can identify. I think the biggest clue is the shortening here. So if we look here at T13, it is longer, but also T11 is longer. So it's unusual to have a shortened vertebra than the one either side of it. This obviously excludes patients such as brachycephalics who might have congenital anomalies here, but in a sort of normal shaped patient, we wouldn't expect one to be shorter. The other clue, I think, is if we look across this central band here, we can see a combination of some lysis, which is where we're passing through the fracture line, but also either side of it, a little bit of sclerosis. So both of these features are a little suspicious, but without displacement, it's very hard to be confident. So I think here, having the orthogonal view is very useful. So one other frequent presentation in emergency medicine is gastrointestinal emergencies. And these, obviously, because our patients have a tendency to eat stupid things, are really a very big mainstay of emergency presentation in imaging. Gastrointestinal emergencies will vary sort of twofold. Firstly, we have patients that have either ischemia or torsion of the bowel. I'm sure most people feel very confident to identify dilation of the stomach and to distinguish dilation of the stomach from torsion of the stomach. So we can see here an example of torsion where we see the fundus no longer being the most dorsal portion of the bowel. And actually, indeed, we can see the pylorus here kind of wrapping outside of the cranial and dorsal aspect of the fundus. So we obviously must have torsion for a start to see the pylorus being displaced more dorsally. And secondarily, if we use a right lateral view, the fact we can see gas within the pylorus is also a clue that this is abnormal. And we can see here the same features, but without the distension. So confirming here a either decompressed or at least a patient that has had a chronic gastric torsion. Potentially a little bit more challenging are patients that present with torsion of other segments of bowel, and we can have either a volvulus, so a torsion of the mesenteric root, which will obviously lead to ischemia of the bowel that's supplied by the mesenteric root. These patients can very rapidly deteriorate and present in a very acute way. What we see radiographically, which is often our first line, is marked distension of multiple loops of bowel, which could be a differential for having a fairly distal obstructive pattern. However, it is unusual to see such a distal obstruction, and we often find that these bowel loops become so distended they start to perform radiographic stacking. So we can see here that the loops kind of align end on end, really because they haven't really got anywhere else to go. The other clue in this radiograph that we see here is we see both loops of small intestine, but also one larger loop here. And this is likely to be a portion of colon. So the mesenteric root supplies the majority of the small intestine, except for the very proximal portion of the duodenum, and also the proximal portion of the colon, so ascending and transverse colon. So this pattern where a lot of small intestine but also a portion of large intestine are affected by this distension, which is because of the ischemia, is quite suspicious for torsion rather than sort of simply obstructive pattern. A variety of papers have been published looking at imaging findings using either CT or ultrasound to evaluate for torsion. And one feature that can be quite useful is identifying a complete lack of Doppler signal. So here we can see the mesoduodenum, there we see a vessel coming in, and we can see there's no vascularization at all. Whereas when we look at the duodenum, which is unaffected, the proximal portion of the duodenum, we can still see vascularization present there. If we get lucky and we follow these vessels up, we may even see them start to whirl and twist round, which is on CT one of the more characteristic features. So always having in mind the possibility of a volvulus case when we see this very distended bowel is worth bearing in mind. We can get torsion just of the colon rather than the whole of the root of the mesentery, and this can either be a torsion, so along the long axis, and or involvement of a volvulus. Occasionally both can present at the same time. These, I think, can be a little more challenging to spot, but here we're looking for evidence that we see one distended loop of bowel, which may even contain something that looks like fecal material and yet becomes very gas-filled, and we would expect it to be in the location where colon may be found, but it may be slightly displaced. And one feature that we find quite consistently with these colon torsions is that the ileocecal junction becomes displaced from this location just to the right of midline over to the left side of the midline. So that can be quite consistent. If we're still unclear, it can be useful to administer a little bit of positive contrast into the rectum. And actually we can see that the positive contrast will fill the otherwise empty distal portion of the descending colon. If we get lucky, we may even see it narrow and start to twist, and then we won't see any filling of this more proximal portion, as the contrast can only really reach the level of the volvulus itself. The other thing that can keep us puzzling when it comes to GI pathology is an obstructive disease of the small intestine. And I think imaging is absolutely critical for this kind of decision making. Are we going to take this patient to surgery to relieve the obstruction, or is this patient one that is actually undergoing functional disease such as gastroenteritis, and approximately the last thing that patient wants is for us to take it to surgery and give it something else to recover from rather than supporting it medically. So we will try to look to see if we have evidence of obstruction if we take screening radiographs of these patients showing clinical signs that would be consistent, such as severe or persistent vomiting. This patient was ultimately confirmed to have an obstructive disease. It actually had a radiolucent foreign body, and here we had some distension of the small intestine, although actually only a few loops of small intestine were affected, and they had a mixed content of gas, as we can see here, and the majority of the affected loops of bowel were affected with fluid within that bowel. The reason we can start to raise suspicion that this is obstructed is twofold. Firstly, because of the degree of distension of these segments, and we're going to talk about markers for evidence of obstruction shortly. But actually the main feature for me is that we see a couple of loops of bowel that are affected by this distension, whereas the rest of the small intestine is not distended. And these two features together, so marked level of distension, and also the presence of two populations, so distended and non-distended bowel, would be features that would be worrying for me for the presence of an obstruction. We can see that there are a variety of different normal values that have been published to help us say whether this patient has a normal amount of distension with just a little bit of gas that happens to be passing through the bowel, or whether there could be genuine progression to a mechanical obstruction. One quick ready reckoner that I like as a sort of eyeballing measurement is to compare the widest loop of bowel to the height of L2. Other publications have suggested the last rib, which I have to say I don't particularly like, because I think the last rib can have quite a variable thickness, so I don't find that a useful measure. The one that I think is employed the most in the decision making is to measure the midpoint of the height of L5. An initial publication around about 20 years ago had very strong data that if your loop of bowel had a height of 1.6 times that midpoint of L5's height, then this was actually a strong indication that the patient had mechanical obstruction. And so actually this was kind of bandied about as being a very accurate predictor. Of course, we've had more recent publications that have reevaluated this finding and actually found that there's a little bit more of a grey zone than perhaps we would have understood from the initial paper. So this is a more recent paper around about 5-6 years ago, in which the initial study was redone, and they showed that actually it was only patients that had a measurement of over 2.4 times the height that were consistently mechanically obstructed. Having said that, patients that had bowel that was less than 1.6 times were very unlikely to be mechanically obstructed. So while it's not quite as clear cut, we've got quite a big grey zone now between these two measurements. If it goes below or above, then we can have a reasonable degree of confidence. I should add that these measures are for dogs, and with cats we can use the height of L4, or because cats are a little bit more of a standard range, somewhere up to 12 millimeters from one side to another. So another feature that is very satisfying to help us identify if we have a possibility of obstruction is actually seeing the foreign body itself. So I'm just going to put in a couple of radiographically characteristic appearances. Here we can see the typical appearance of a corn cob foreign body. So they're rectangular in shape, and you can even see the kind of heterogeneous appearance that is sort of this wavy opacity superimposed on it where the actual corn cobs are. We can see here another corn cob foreign body here, but actually in this situation, not in the stomach, actually separately lying within the small intestine and potentially causing obstruction. Alternately, you may have a rubber or plastic structure, and depending on the sort of composition of rubber and plastic, some of these will actually be radiographically visible. So here we could see what looked like a very small person causing obstruction in this patient. So there's the corn cob appearance, and this was actually what we took out of this patient here. So when they're radiographically very clear, then I think that increases our ability to be confident that it's a foreign body causing the gastrointestinal signs. Unfortunately, a large proportion of the patients that we see do not have the same sort of consistent appearance of a radiographic foreign body that is clear and solid as we see here. Here we've got 3 examples of foreign bodies that were a little bit more challenging for us to identify. In this particular case, this is colon, which is quite voluminous and distended. And here we could see a loop of bowel that had very odd appearing content. It looked almost like gas, but with a layered appearance of soft tissue within it. And this turned out to be a plastic bag causing a degree of obstruction. Down here, we could see again evidence of quite markedly distended loops of bowel because of the obstruction. And then the obstruction was actually this structure here, which again had gas trapping within a layered soft tissue appearance. And this was cloth identified. And finally, we have this particular patient. This was a left lateral view, so we'd expect to see gas within our pylorus, and actually we could see soft tissue in the pylorus. And when this patient went to gastroscopy, this ended up being a quince, which was causing the foreign body. I find the radiographic appearance of foreign bodies one of those things that is endlessly fascinating. And for people who share my fascination in the stupid things that dogs will eat, then Veterinary Practice News in the US annually holds a X-ray contest for the most bizarre things that patients can eat. Some of them are quite frankly frighteningly alarming, but they do help to increase your familiarity with the difference of appearances. Sometimes we will identify a stomach which appears to have very heterogeneous content within it, and honestly it's very difficult to distinguish heterogeneous content from just normal kibble that's been eaten and sort of mashed around a bit in the stomach, so from normal ingesta. And we've got a couple of options if we have this kind of appearance presenting in a patient that is vomiting. We can't rule out the presence of a foreign body, but it seems perhaps a little dramatic at this stage to go straight into gastroscopy, particularly if we haven't got a known ingestion of a foreign object. So we've got a couple of options. One is to wait and see, which there's very rarely any harm in the wait and see approach. Perhaps re-radiograph this patient after it's been starved for 6 to 12 hours. Is that stuff still within the stomach, which implies that perhaps we have some outflow obstruction, or that this is foreign material and is unable to pass? We could put the ultrasound probe on, which certainly if you have good experience of GI ultrasound can be very helpful in confirming the presence of foreign bodies. But they can be a little challenging if you're not comfortable with the ultrasound probe. Another option, of course, is to administer barium. This was an initial radiograph where we'd recently administered some barium, and you can see there's quite a large amount of contrast here in the stomach at this time. It has a slightly odd appearance, a bit heterogeneous, but really we can't tell what's going on. Actually, for these foreign bodies to be identified, one thing that can be very useful is to wait a bit of time and then re-radiograph the patient. We can see that the majority of the contrast now has reached the colon. There's almost nothing left in the small intestines. And yet we can see that barium is coating something which is still remaining within the stomach. And that, coupled with the fact that after at least sort of 4 to 6 hours, so we have contrast move through, this amount of content within the stomach has not reduced. This was actually a patient that had some Gorilla Glue left in the stomach, which is sort of a particular type of adhesive which unfortunately swells up with contact with stomach juices and can cause a big concretion within the stomach and be genuinely very difficult for the patients to manage and has to be removed. So using contrast can be helpful not only for presence or absence of obstruction, but actually for its method of coating the foreign material as it remains in place. So say we're not confident that we have distension to indicate a mechanical obstruction, then we have to think about our differentials for a functional ileus. And many different things can cause this, both primary GI disease such as enteritis, and actually this was a cat that had gastroenteritis. We can see there is gas within the stomach and quite a lot of gas here within the small intestines. No one loop is larger than we might expect. If we had the vertebrae on there, we could rule in or out the presence of whether it was larger than the height of L4, but certainly these are what we'd expect. If we look closely, we can see that the margin of the gas can be a little bit irregular, which again can be a bit of a clue towards gastroenteritis. But many other non-gastrointestinal diseases will also lead to a degree of functional ileus, everything from neurogenic abnormality to drugs that have been administered to other diseases such as recent surgery. So this is much more common, and the presence of gas itself is not enough. We have to apply those other markers we've already spoken about. So let's have a look, just as we're sort of coming towards an end here, at this tricky case that we can see. This patient has presented, it vomited yesterday and has had a period of time without vomiting, but now has returned to vomiting. And on sort of closer discussion with the owners, it actually presented to a different vets last week for retching and was actually given an anti-nausea medication at that point. My first glance at this is to say, well, I'm not seeing huge loops of bowel that are distended. However, I do see some gas here within the stomach, which is where we would expect to see gas filling the stomach on a left lateral. It's in the pylorus. And then caudal to the stomach, I can see this heterogeneous looking structure within a loop of bowel. Now, if this loop of bowel is colon, and I guess it's not impossible that this is colon, then we could say then that would be normal. Potentially this might be a portion of fecal material, and then the remaining colon, which I suspect is here, is relatively more empty. But if this was within small intestine, then that would be a very worrying sign. So let's have a look at where it ends up being on the VD view, because as with thoracic radiographs, then we really need to have our lesions triangulated. So ideally we would do a left and a right lateral and an orthogonal view. And we can see here we have the colon coming up on the left-hand side. And then we see this odd region of heterogeneous opacity here on the right-hand side. So I'm still not sure if this could be ascending colon or whether this could be small intestine. So I'm going to give you guys a few minutes to just have a bit of a think about what you might do in this case. And I've given some hopefully sensible options that you could think about, ranging from those that are keen with a scalpel, who cannot bear to have any doubt in their mind and want to get right in there, let the demons out, and find out whether that's foreign material or feces. And then some other options for those that are perhaps more interested in imaging. Maybe they want to do an ultrasound, maybe they want to do a contrast study. Those that are keen to hand this over to the next shift and suggest that we just recheck this patient in 12 hours, given it's not vomiting that severely, we have some time. And then those that are confident that it is in the colon, and they're just going to give it some laxatives and let nature take its course. So shall we have a little look, Beth, at what people are thinking they might do? Yeah, well, that's nice. So we've got a really nice range of things. And actually, I don't think there's necessarily a right or wrong answer with this one. I'm going to show you what we opted for. But actually, I think all of them, except maybe the giving laxatives, that is maybe a little unadventurous. So I think for all the others, I think there are merits to be discussed. And I'm interested that people went for ultrasound. And actually, that would often be my first choice. I do like getting the probe on these patients. I found this one particularly interesting because actually we worked through in a different way and did a very simple test while we were still in the X-ray room. And that is a pneumocolon, which I think we probably underemploy as a method of contrast. So instead of all the faff of administering barium orally, just inject a little bit of gas into the colon. We can use somewhere between 1 to 3 mils of gas is usually enough to get good distension of that colon. You have to be careful to instill it slowly because obviously we don't want to apply too much pressure and end up with any risk of rupture. But actually once carefully applied, we can do that relatively safely. And we can see here that this is our descending colon wrapping around the ascending colon. This will be the cecum here. And despite this being nicely aerated, we see a marked amount of abnormal material distending another loop of bowel. So this therefore must be a foreign object within the small intestines. If we look here on the VD view, we can see we have the colon highlighted nicely by gas, and here we can see that abnormal content that is clearly not in the colon. So I certainly wouldn't do a pneumocolon in every case, but I just want to sort of share that with you as an alternative option that I think we perhaps underemploy if we have a doubt about whether something is fecal material or perhaps whether this might actually be, rather than fecal material, some small intestinal abnormal material. I think we will just bring things to a conclusion at that point. I have just put up this slide here and will maintain my sharing for now, but I'm going to hand you back over to, is it Beth or Gemma who wants to come in at this point?
Hello. Yeah, so thank you very much, Abby. And I'm sure everyone will agree that there were some really useful tips to take away there. So we will now open up for any questions for the next 10 minutes for either Abby or about the programme in the chat box. And I'll also put the link in the chat box for the certificate. So please don't forget to pop your email address into there so you can receive your certificate of attendance.
Okie dokie. So Abby, are you ready for some questions? Firstly, thank you very much for that talk. It was brilliant. And we've got quite a few, so we'll see how many we can get through. But if we start off with looking back at the pneumothorax, do you tend to drain all of your pneumothorax cases, or are there some scenarios where it's worth sitting tight and monitoring them? And what are your sort of cut-offs as to whether you need to intervene or monitor?
So that's both an easy and a difficult question to answer because there's so many variables involved. I think with most of these things, imaging is rarely the only cutoff. So we would need to take into account the patient's status and progression of the patient over time. In cases of the tension pneumothorax, that's the one that we would never argue with. Once we start seeing evidence of tension and displacement, then obviously that has to be drained. If there's a very small volume pneumothorax, usually we would initially sit tight unless the patient was showing overt signs of marked abnormality. Having said that, there's then quite a big grey zone of the moderate pneumothorax, and with those really it will be dependent on the initial imaging. If there's any evidence of respiratory difficulty, then they would be drained, and then we may just sit tight and not do anything further and only re-image them dependent with a timescale kind of dependent on how they're doing.
Brilliant. Thank you very much. And this one particularly interested me as I'm renovating a house at the minute with my dog around. Is Gorilla Glue hard to remove? Does it irreversibly attach to the stomach lining, or is that a surgical?
I don't think so. It's a surgeon's question, really, but it becomes this. My understanding is it becomes this great big conglomeration within the stomach, like a big solid mass, almost concrete mass. So I think it's not so much that it's going to adhere, like it's not going to glue itself to the inside. It's the physical effect of forming this big sort of stone within the stomach. So the surgeons would then usually remove them because they're so expanded. They're often not possible to remove with gastroscopy, I understand.
Okay, thank you.
It's not nice stuff. It's great for sticking things, but not inside a dog. And why they eat it, but it must be tasty to them, I guess.
I'm sure there's something nice in it. And then the pneumocolon, the contrast study, are you using just plain fresh air for that?
Yep,
or
room air is fine. Yep, just a syringe and a Foley catheter.
Okay. Brilliant.
Very simple. I like things that are simple and cheap, and you're in X-ray. You don't even have to move the dog, so it can be very useful.
Yeah. And do you have any sort of a waiting time, or do you literally do it and by the time you've taken the next film, it's
yeah. It should be good to go. You instill it relatively slowly, and there is always the worry that it will leak out. So actually you don't want to faff around for too long. I'm just seeing a question, what was the amount of air? It's estimated to be 1 to 3 mils per kilo, but that's sort of a ballpark figure. I usually would put a bit in. If I get any resistance, obviously I wouldn't give any more. So it's a little bit of a as you're feeling as you administer it.
Brilliant. Thank you. I'll just have a little look and see whether we've got any more. So we've got another question at the bottom here. If in doubt, do you always try and aspirate from a lung?
That I'm not sure what you mean by from a lung. In what circumstances are we talking about? I can't see the question. Yeah.
That's all I've got.
So when would I aspirate from a lung? I think aspiration, like there's not many things that I think, gosh, I wouldn't like to stick a needle in that when I want to find out what is wrong. The concern with lung is obviously making sure that you do it with some kind of guidance so you can pass your needle while avoiding the any aerated lung because you risk getting pneumothorax. So that's one reason why we might do it. If it's absolutely tiny, we might sort of step back and decide not to aspirate that lesion. Actually, one thing we can do, I did it the other day with a patient, was it was quite a small lesion, so we anesthetized the patient so we could breath hold it so it wasn't moving, which gave me a non-moving small target rather than a moving small target, which was obviously less risky for the patient. So you can mitigate against that to some extent. The other contraindication or potential complication, I guess, maybe more correct, is if you have a carcinoma, it potentially has the possibility to seed. And of course, we can seed that and preclude the possibility of a resection. Carcinoma is also the most common neoplasia that we encounter in the lung, so I would always discuss that with or via the clinician with the owner, that if it's a lung mass, it has the potential to seed. So that with those two things put aside, then I don't think there's anything particularly that would stop me from placing a needle into a lung. But would I do it on every case? It kind of depends on what question we're asking, I guess. I hope that answers sort of the question that you're trying to ask. I'm sorry if I've misunderstood it.
No, I think you've done brilliantly. And yeah, just to echo some of the comments that we've got in the chat, thank you so much, Abby, for a brilliant lecture, really informative evening. It's been great fun. If anybody has any questions about the course, you can feel free to email us on the email address that's shown up on the screen there.